seats to be kindly be seated. We'll be starting off with our next session. Repeated implantation failure and recurrent miscarriage. The most enigmatic area in reproductive medicine is RIF and RPL, as we all know. The scenario where both patient and physicians are equally frustrated. It is one of the most researched topics with many unanswered questions. It is with immense pleasure that I invite Dr. Stephen D. Fleming, who can give us new insight on this ever-debatable subject. Dr. Stephen is the director of embryology at Origio. He established the world's first master's degree in assisted reproduction with Dr. Simon Fischel. He's an author and editor of several books, chapters, and numerous articles in peer-reviewed journals. I welcome you, sir.
The organizers of the meeting for inviting me to this wonderful city. I don't know if it's Bengaluru or Bangalore. When my daughter was here for a wedding, it was Bangalore. It's now Bengaluru, I think. But it's lovely to be here, and it's been really interesting to listen to some of the other talks this morning. So when we are going about our normal fields of endeavor, we often get very focused on our particular approach to problems associated with fertility. But in fact, the prognosis of a patient is affected by potentially many different factors. So particularly when we're looking at problems like recurrent miscarriage, they can often be multifactorial. So we need to be aware of all these different kind of factors that might have an impact, particularly things like maternal age, the reproductive history, number of implantation failures, miscarriages, etc. And also male factor and lifestyle. And I think it's one of the benefits of coming to conferences like this, where we hear about talks on hepatology and renal failure and all these kind of things, that we start to understand better how many different factors can impact these patients. So when we are talking about recurrent implantation failure and recurrent miscarriage, we're really talking about poor prognosis patients. And we can break these poor prognosis patients down into perhaps these three different categories. Those that are suffering recurrent implantation failure, and we define that as a failure to achieve a clinical pregnancy. It should be identified by a fetal sac after the transfer of at least 4 good quality embryos in at least 3 cycles, whether they be fresh or frozen. And then we have the recurrent miscarriage group. Now there are various definitions of this. I think probably the best one is the ASRM one, which is the definition of 2 pregnancy losses during the first and second trimester, but identified by products of conception or other histological means. So it's a verified pregnancy loss. And then we have this idiopathic group who can be represented by advanced maternal age. We know that there are genetic problems as women get older, underlying genetic issues that may be present, phenotypic issues. We often see this in terms of poor quality oocytes, and of course iatrogenic causes. And I'm a firm believer that not all patients' embryos do as well in the in vitro culture environment as others. And when we think about these groups all together, they actually represent, it's been estimated, about 20% of all the patients that we treat. So what can we do in order to try and resolve these issues that they may have? Well, there's been a number of different strategies that have been developed, which are based upon published evidence. And you can see that most of them attack the problem of both repeated implantation failure and recurrent miscarriage. And I'm going to be talking about sperm slow, which is a hyaluronan solution, and PIXI, which is hyaluronan in a dish, and the hyaluronan binding assay to identify which patients may benefit from these kind of approaches. And then, of course, because of up to about 50% of recurrent miscarriage, for example, has a genetic basis, I'll also be talking just briefly about PGTA and PGT-SR. But also I think that what's very interesting is the development of new culture media aimed at trying to improve the communication between the embryo and the uterus in terms of telling a uterus that the embryo is viable and should be allowed to implant and remain implanted. And also, following on a bit on the earlier talk this morning, looking at endometrial receptivity. So what's the rationale for using hyaluronan? Well, this is a glycosaminoglycans, which we know that the sperm binds to on the cumulus cells, and that we know that there's this GPI-anchored hyaluronidase that helps the sperm migrate through the cumulus cell matrix after binding to the hyaluronan, and then the sperm again binds to hyaluronan in the zona pellucida, and then there's acrosomal hyaluronidase that helps the sperm to get through the zona pellucida. So this is a naturally occurring glycosaminoglycans, and sperm binding to it is fundamental to fertilization. And we know that those sperm that can bind to hyaluronan display greater cellular maturity, less incidence of aneuploidy, less incidence of DNA fragmentation, better chromatin integrity, and better morphology. So it seems to be an indirect assay for the best quality sperm. Now, we can use the hyaluronan binding assay to identify the proportion of sperm within a semen sample or within a sperm prep that are able to bind to hyaluronan. And this is how this HBA slide is used. We can put a sample on the slide, and we apply a cover slip that has a grid which helps us count the number of bound sperm that are showing motility but are not able to locomote because they're bound to the hyaluronan. So if we see a low score, we know that there's more likelihood that we're going to get a poor quality sperm that might fertilize an egg or that we might inject into an egg. So it's a way of identifying those patients that may benefit from further intervention. And we know also from some studies that the level of the binding score, so you can see from less than 15% to less than 60% there's a significant correlation between higher fertilization, cleavage rates and pregnancy rates with a higher binding score to hyaluronan. So this, of course, is reflecting the paternal contribution to embryo quality. Now we can exploit this interaction between sperm and hyaluronan, for example, using physiological ICSI or PIXI, which is where we use a PIXI dish that has drops of hyaluronan on the dish that we can rehydrate, allow sperm to bind to, and then we can use a micro-injection micropipette to pick up those sperm that are bound to the hyaluronan and choose those preferentially to inject into the oocyte. And this study shows quite beautifully how efficient this approach is. Because if you, this is obviously just an experimental system here, but if you fix these sperm in a PIXI dish that have been so fixed with methanol and acetic acid and then stained with acridin orange. Now, acridin orange is a stain that we know will undergo a metachromatic shift in color between green when the DNA is native double-stranded and red when it is fragmented or single-stranded. And you can see, just by looking, that the vast majority of sperm that are bound to the hyaluronan drop there are stained green. In fact, it's over 99%. So it gives you a much greater chance of picking up a sperm with intact double-stranded DNA. And that is important because studies have shown, this is actually looking at sperm slow, which is hyaluronan in solution. So you can use either a pixie dish or you can use a drop of hyaluronan in solution in sperm slow. And this study showed that there was a significant increase in the implantation rate if you chose sperm using sperm slow versus just arbitrarily picking the sperm out of some PVP. And in terms of the type of patients that may benefit from this kind of approach, this study here showed quite clearly that when we start looking at things like pregnancy loss, which of course is more likely to happen when fragmented DNA in sperm are used, then you can see that particularly when the sperm binding is less than or equal to 65%, so in other words, a poor binding score, then you start seeing these highly significant reductions in the rate of pregnancy loss when sperm are selected using hyaluronan. Now, this study was followed up by a very large multi-center study, a randomized controlled trial across many centers in Europe. So they were looking at over 1,000 patients in each arm of this study. So this was a PIXI study versus ICSI study. And the primary outcome was the term live birth. And they did find that there was a slightly higher term live birth in those patients where sperm was selected using PIXI. But where there was very clear difference was in terms of the miscarriage rate. So there was a highly significant reduction in the miscarriage rate in the group of patients which had PIXI. And this is precisely what we would expect, that if you can avoid selecting a sperm carrying fragmented DNA, then yes, you will reduce the miscarriage rate. And of course, it's like a seesaw. If you reduce the miscarriage rate, you have to ultimately improve the live birth rate. So what about the idea of adding various growth factors and survival factors to culture media? So this is based upon the known interaction between the embryo and the uterus. We know that there's this continuing communication from as early as fertilization all the way through to implantation. And we know that at the critical time of conception and implantation, that there's a massive increase in a whole range of various cytokines, growth factors, and survival factors. I've listed a few of them there. There's a few other cytokines that tend to be reduced at this time as well, but they tend to be anti-conception cytokines. So we know there's this, we believe there's this interaction between the embryo, this ongoing crosstalk. So the embryo is being supported by the uterus to develop, but the embryo is also telling the uterus that it's viable and should be allowed to implant, and also to remain implanted. So what's the evidence for this? Well, the evidence for this is somewhat beautiful. So this is some immunofluorescence studies that were conducted on human embryos and looking at this range of various cytokines and growth factors. And you can see here including granulocyte macrophage colony stimulating factor. So they looked at the ligands, in other words, the proteins within the embryos on the left-hand panel. And you can see that apart from the negative control, all these embryos were producing all these cytokines and growth factors. And they also looked at the receptors in the right panel for those same ligands. And you can see again that the cell surface of all of these embryos were expressing the receptors for these different ligands. So these embryos can obviously both produce and receive these various cytokines and growth factors. And indeed, when you look at the mid-secretory endometrium, and you look at the same group of cytokines and growth factors, either by gel electrophoresis or immunostaining of endometrial sections, again, you can see that these whole range of these cytokines and growth factors are being both produced within the endometrium and being secreted from the secretory epithelium. And it's significant that in this study where they looked at the systemic circulation of one of these, GM-CSF, and they compared women that had a normal pregnancy versus women that had had previous miscarriage, you can see that the normal profile was a rapid increase in the first trimester of pregnancy, a slower increase, but still increasing during the second trimester in terms of GM-CSF, whereas those women that had not, or that had suffered a previous miscarriage, you can see that their levels of systemic GM-CSF barely got off the ground. So one of the inferences, of course, is that maybe the embryos that they're trying to get implanted are not being supported by GM-CSF within the maternal circulation. So this brought about the rationale, admittedly after about 20 years of research, looking at various animal models to see how embryos developed, etc., in the presence of this cytokine. But nevertheless, it brought about the development of these 3 different culture media containing quite low levels, 2 nanograms per mil, of GM-CSF, but that's physiologically active levels. It's a very potent cytokine. So in EmbryoGen, BlastGen, and one-step medium, GM-CSF designed specifically to support the development of the embryo, and probably particularly in these poor prognosis patients. And there's also some evidence that when you do an embryo transfer with media containing the GM-CSF, there may be benefits there as well. So there was again, a multi-center randomized controlled trial conducted in Scandinavia, looking at over 500 patients in each arm of the randomization. And they looked at both the full study, but also in a subgroup of those patients that had experienced a previous miscarriage, where they saw even more significant increases in terms of ongoing clinical pregnancy and live birth rates in those patients where their embryos had been cultured in the presence of GM-CSF. Now, there's been a range of other studies that have been published. I'm only going to show you a couple that I think are quite profound. This one in Germany, they compared their control group of patients versus their group of patients having EmbryoGen with GM-CSF. And you can see that the pregnancy rate per transfer, of course, went down with increasing age in the control group, but remarkably, in the group where their embryos were grown in the presence of GM-CSF, if anything, the pregnancy rate per transfer was improved in the older women compared to the younger women. So it did seem to be supporting the embryos of these older women. The other way you can look at this is by, again, looking at this group of poor prognosis patients, advanced maternal age, recurrent pregnancy loss and repeated implantation failure. Admittedly a small study, but here what they did is they used the same patient as their own control. So they compared their initial cycle using their standard medium and compared that with a subsequent cycle using media containing GM-CSF. And as you can see, there was a doubling in the clinical pregnancy rate and almost a tripling in the fetal heart rate in the subsequent cycle in the presence of GM-CSF. So there's now a growing evidence that culturing embryos, particularly in these poor prognosis patients, improves their outcomes in terms of live birth rates, ongoing clinical pregnancy rates, and also in terms of preventing pregnancy loss. So the other side of the story, of course, is that about 50% of these problems, at least with recurrent miscarriage, might be explained by genetic factors. And so the other approach, of course, is to do biopsying of the blastocyst and then doing diagnosis of the biopsied cells. For aneuploidy, for example, so we now have a system building upon big data and by machine learning, developing more accurate diagnoses. So this is the so-called PGT AI technology platform. It's based on over 1,000 pregnancy outcomes, 10,000 or more embryos, and so it's become more and more accurate at diagnosing if an embryo is euploid versus aneuploid. And the evidence is quite clear. This is the SART data that shows if you look at increasing age of patients and you compare those patients per transfer between not having genetic diagnosis for aneuploidy versus having genetic diagnosis, you can see that in terms of the miscarriage rate, which we know increases with maternal age, you can pretty much blunt that by only transferring euploid embryos in those older patients. And likewise, in terms of the live birth rate, which we know decreases with advanced maternal age, again, you can very much blunt that decline in the live birth rate, again, by identifying embryos that are euploid. So it seems that the disadvantage for the older patients is simply that they have a high proportion of aneuploid embryos. But if you can identify the euploid embryos, then they have an excellent chance of avoiding a miscarriage and ending up with a live birth. However, there are still some perceived limitations of PGTA. We know that, yes, it decreases the risk of miscarriage in these older patients, but it doesn't completely eliminate that risk, and that's why we look at other ways of trying to reduce the risk of miscarriage. So usual prenatal monitoring is still the standard of care, and we know that the euploid status is a very good indicator of the genetic competence of the embryo, but of course there are other factors that come into play in this multifactorial problem of recurrent miscarriage in particular. So the assumption, of course, is that the trophectoderm cells represent the inner cell mass as well, but that may not always be true. And also, of course, the other side of the equation is endometrial receptivity. And then there will be these other biological phenomena, one of which I'm pretty convinced includes signaling by the embryo to the uterus. And so there are many other factors that are involved in determining whether an embryo implants and whether it remains implanted. So one of the concepts which I've been encouraging actually some centers in India to look at is to see whether you can get a complementary effect of both culturing your embryos in the presence of GM-CSF and biopsying the embryos and using PGTA to identify the very best embryos that you can transfer in this particularly compromised group of poor prognosis patients. So probably we will arrive at a stage where we will combine two or more approaches to solving these problems in these poor prognosis patients to give them the maximum likelihood of ending up with a live birth. Now, one of the other areas, of course, is structural rearrangement of chromosomes. We know that about 1 in 200 individuals is a carrier of balanced chromosome rearrangements, and we know that these can impact on miscarriage in these patients. So if we do karyotype screening of these patients, we can at least identify those that might then benefit from PGT-SR in terms of, again, identifying embryos that are more likely to implant and remain implanted. And then, as I said, the other side of the equation, which Dr. Satish addressed very nicely this morning, is that of endometrial receptivity. So these days, probably the most efficient way to look at endometrial receptivity, again, because it's impacted by so many different factors, is to look at the genes that are involved in the expression of those proteins that are involved in receptivity of the endometrium. So we can in a woman's cycle, we can do a biopsy. We can then send that biopsy off for analysis and get a result. And then in a subsequent cycle, we can get a better idea that for that woman, whether a typical time of transfer is appropriate or that we need to adjust that transfer time. Because we know, for example, that supraphysiological levels of estradiol will bring the window of implantation forward earlier. So particularly in those cases, we'd probably want to avoid a fresh embryo transfer. So again, there's this targeted approach, in this case based upon so-called ER-peak, again based upon quite a large amount of data in terms of identifying which genes are most predictive of the receptivity of the uterus. And there's been some studies on this looking at the so-called personalized embryo transfer for these repeated implantation failure patients. And you can see that in terms of the implantation, the ongoing pregnancy rate and the live birth rate, although the numbers are not yet sufficient to achieve statistical significance, there's nevertheless a suggestion that by using personalized embryo transfer, you do improve the rates of these clinical outcomes for these poor prognosis patients. So what can we summarize and conclude from all of this? Well, these poor prognosis patients of advanced maternal age, repeated implantation failure, and recurrent pregnancy loss, they may benefit from sperm selection. It's quite clear now that PIXI will significantly reduce the miscarriage rate in patients. And they may benefit from the addition of this growth and survival factor, GM-CSF, to the culture medium, because again, there's many studies around the world now that show that this cytokine significantly increases ongoing clinical pregnancy and live birth rates, particularly in those patients that we would put into this poor prognosis group. And then again, we believe that poor prognosis patients may also benefit from things like PGTA and PGT-SR, because again, in women across the board, it's shown that comprehensive chromosome screening of blastoma biopsies significantly reduces miscarriage rates and increases live birth rates. And there's encouraging data that poor prognosis patients may also benefit from assays of their endometrial receptivity and personalized embryo transfer. So I think we now have an armory of different techniques to, I think, better tackle these patients. But we need to keep an open mind. We need to be looking at all the factors that might be affecting these patients, not least what we do to them in the laboratory, and try and work out what is the best approach on an individualized patient treatment basis in terms of what may help them best as a couple to achieve a pregnancy. Thank you very much.
Thank you, sir. Thanks for uncovering the topic for us. It was a very informative talk. Thank you. Let's move on to our next session, the symposium.